Good morning, everyone. Thank you for joining our AOS webinar today. And good afternoon if you are in Oman. If you are in England and still suffering from the heat because you don't have air conditioning, thank you so much for being able to join us for this. My name is Dina Macki, and I'm really excited to welcome 4 incredible speakers from Oman and the UK. Today we have with us Dr. Hamed Al Sinawi, Her Highness Sayyida Basma Al Said, and from the UK side we have Dr. Richard Heron and Eileen Pepple. So today's discussion is focused around unraveling stigmas and what we like to believe is the universal language of mental health. And I couldn't think of a more better time to be discussing this, having had the last 6 months in a pandemic, and probably this being the most relevant conversation right now. People are talking about it more, people are acting on it more. And so really I brought our panelists today to kind of discuss the differences and similarities between both countries and East meets West, but also to tell us about their challenges and what they view as kind of the common stigmas around mental health. So I'm really excited to bring you these speakers today. A few disclaimers. Each speaker will be speaking for 10 to 15 minutes, and we will have a Q&A session at the end for 15 minutes. So if you do have any questions, feel free to just drop them in the Q&A or chat section, and we will try and get through all of them at the end. If we don't get to your question in time, I promise to pass them on to the relevant speaker so that they can be answered for you at a later date. Another disclaimer, in case we run over 12, Eileen does have to leave promptly as she's in the middle of patients, as she does work for the NHS. So thank you so much, Eileen, for managing to squeeze that in. And thank you so much to all of the speakers for being able to squeeze this in to their busy schedules. A brief about the speakers. To begin with, we have Dr. Hamed, who is a Senior Consultant Psychiatrist at Sultan Qaboos University Hospital, and he is the chairman of the Omani Alzheimer Society. He has a special interest in elderly mental health and Alzheimer's disease. Dr. Hamed did his postgraduate training in the UK and completed his fellowship at the Old Age Psychiatry from the Royal College Hospital in London. He established the memory clinic at Sultan Qaboos University in 2011. Her Highness Sayyida Basma Al Said is a visionary agent of change who tirelessly champions the modernization of mental health in the Sultanate of Oman and has become an icon for reform across the whole of the GCC. She founded Whispers of Serenity, the first clinic of its kind in Oman to provide a holistic range of psychotherapy services to men, women, and children suffering from mental health. Dr. Richard Heron is the Vice President, Health and Chief Medical Officer and responsible for strategic development of the BP Group's health agenda, including employee well-being, occupational health and hygiene, community and public health in the locations where BP operates. He also holds an honorary appointment as Professional Fellow of International Business and Health at Nottingham University and is an honorary teacher at the University of Manchester. And lastly, Eileen currently works at the Increasing Access to Psychological Therapies, also known as the IAPT service in Lewisham, London. IAPT is a service that provides psychological support and to anyone that needs it for free by the NHS. The main goal is to get people psychologically well enough to work and has a holistic approach to supporting mental health well-being. So you've probably all had enough from me, and that was some amazing titles to read through. I would like to now pass it over to begin with Dr. Hamed beginning our conversation. Thank you so much, Dr. Hamed.
Thank you, Diane, and thanks to your colleagues at the Anglo-Omani Society for arranging this beautiful meeting to exchange ideas and thoughts from with our colleagues from the UK. And I'm pleased to share our experience here in tackling stigma to mental health in Oman.
Thank you.
Sorry, Dan, you want to ask me a question or should I just start talking?
No, please continue. Just
yes. So basically, stigma to mental health is an important topic. It's a worldwide issue that different people from different countries are facing. And it's in Oman, when we first started, mental health was quite new concept. And we had to come across common themes and misconceptions about what causes mental health and how do other people in the community perceive people who have mental health problems. So common themes were that some people used to think that people who have mental health problems are less of a Muslim, they don't have a strong faith. Other people might think that mental health problems are caused by evil eye or bad spirits or bad luck. So according to such beliefs, this will influence how people seek help from professionals. So those people who think it's related to evil eye will seek help from traditional healers who, well, most of the time they don't know how to diagnose people, and the person have a problem, delays in getting professional help. Sometimes people with mental health are perceived as being spoiled or have weak personalities or dangerous. So some of those common misconceptions are universal, as probably my colleagues will agree with, but it's important to establish what is the situation in the Omani culture. So initially we had an interest in identifying those common thoughts, and so people when come to clinic, we'll ask them, what was the reason you had this delay in seeking help? Although you're seeing the person that living with you is deteriorating, they're unable to attend to their studies. If there are students, they are unable to perform their jobs or their duties. And they'll probably say, when we ask around, people told us this is something that a local healer will probably help with. So it was important for us to establish what is it that local healers have. And most of the time, I think it boils down to probably being seen as part of the community, and they don't have that stigma issue, because if people come to see a psychiatrist or a psychologist, the rest of society will label them as crazy or mad or not very, not very good up in their head. And this will stop people from seeking help. So it was interesting that we went around doing surveys looking at the public perception. How do they think of mental health problems? What is it they think about people who have mental health issues? Because the impact will be not just related to those who will have the family members who will need help, but also other members who would probably, for example, if you have to work with somebody who has mental health problems, you will sometimes patients feel discriminated at. Their boss will think they're not good enough to do their job, or probably they are a liability. They are more likely to be at risk or putting other people at risk as well. So it goes beyond just seeking mental health, seeking professional health. Also, when it comes to people who are in the elderly group, they're often stigmatized in a different way. For example, it's interesting to observe that when it comes to causation, people think it's kind of normal for elderly to forget or to become slow in performing activities. So even if the person has a clear symptom of dementia, the family will fail to identify that, and they think that was a normal part of aging. So that was helpful for us when we're designing our health education program to target those certain issues. And it was interesting that when it comes to the spiritual or the evil eye, it's unlikely that an elderly person will be thought of as being affected by evil eye, because the meaning is usually carries that usually you have to be special. You either are rich or you're knowledgeable or you're young and healthy for evil eye to kind of affect you. This is the kind of cultural belief. So it was interesting that such belief changes within different diagnoses or different age groups. And it's also talking about elderly, it brings the issue about abuse, although it's an issue that is unspoken about, it's a taboo. But it also, we needed to tackle this in a very kind of sensitive manner, because obviously we don't have a dedicated service. So it's, for example, if you identify there is abuse in the family, you have to deal with it within. So we don't tend to probably criminalize the abuser. And most of the time it's a family member who is stressed because they are doing all their caregiving behavior. They are looking after the person along with juggling their personal life, bringing up their children, keeping a job. And most of the time we try to ask the question, what is it that causes this person stress, and how does this stress lead to the person being a kind of unkind or abusive or neglectful to their elderly person, and how can we work around it? And it was very interesting to notice that just having that dialogue makes this very easy for people to come up and express their distress, because from a family perspective, we've been observing dramatic change in the social structure in Omani society. So traditionally, a few years ago, the extended family was the norm. So the couple will be staying with their older parents, with their aunties and uncle in a bigger house or like a compound. So there's always somebody around to help looking after the kids or look after the elderly person. But gradually with the modernization, people moved into a nuclear small families where the couple will be living with their children And if there is an elderly person, most of the time they'll be left on their own. So either looked after by a housemaid, or if needed, they might have a special carer to look after them and to attend to their needs. So this created a new situation, because we've noticed that the elderly people come up with symptoms of depression because they feel lonely, or they have what we call somatization, where a person will have a multiple physical symptoms, but there is no cause for it. There's nothing wrong in their bodies. But this physical pain, for example, is an expression of a psychological distress. So again, working with the family, getting to develop that trust, and because for the people who come to our clinic, they are a little bit confused. We look like them, we are like them, we are from the same cultural background, but we don't subscribe to when it comes to issues like evil spirit or causes to the mental illness. And initially, we had to bridge the gap, because I, as introduced by Diana, I was trained in the UK. So for me, it was important to borrow the kind of medical knowledge from the UK, but adapt it so it make it more acceptable to my patients and the families, because people would easily cast you as looking foreign or speaking a foreign language and, you know, importing ideas from the West. So it's again, how do we make that knowledge more acceptable or more relevant to our society? And when it comes to kind of working with the stigma campaign, we learned to kind of borrow some of the brilliant ideas that has implemented to the West. And I quote specifically Professor Graham Northcroft, who started the idea of social contact. And maybe most of you are aware of the idea that people who have mental health problems might be kind of the presidents of change. So for example, they would, those who are well can be part of the awareness campaign, they can join, they can share personal experiences. And we've done this probably more than 3 times. In one occasion, we invited 3 people who had history of mental health problem, who are still as service users. And we had event for university students. And one of the patients had bipolar disorder. The other was a student who had OCD, and the last one was a recovered drug addict. So it was quite interesting for the student to see those 3 people emerging from the audience to come and speak about their experiences. And it was very touchy for people to see that a person might look normal, quote unquote, in a sense that no one can notice this person is having internal suffering, and they could be just sitting part of the audience, but they actually had a very interesting story to tell. They struggle a lot, and with support and help and mental health care, they could achieve their goals. My bipolar patient was able to complete his PhD, and that was a big achievement for him and for others to inspire other people. So such initiative, we wanted to be slightly more kind of go out beyond the traditional of celebrating or marking World Mental Health Day or World Alzheimer's Month or World Depression Day or such things. So we wanted to make it an ongoing issue. So mental health is not just something to be celebrated on those specific days or days of the year, but something that we always talk about. And with the help of social media, people have been doing great jobs. My colleague, Dr. Sayyida Basma, will share her experience, how your presence in social media, things like correcting kind of unhelpful language. So when somebody says so-and-so is schizophrenic, you'll say, actually, the word is someone with schizophrenia. So you don't label the person. The person is not their condition. And when somebody posted about suicide, saying successful suicide, so I will just chip in and say, excuse me, there is nothing successful about taking one's own life, and it's nothing to be mocked about. And this initially allows other people with mental health problems who are very shy and kind of didn't want to share their experience. This made them feel a little more comfortable to share their experiences, either through their personal blogs or by posting stories, and by for example, being a kind of ambassador of change. And when it comes to people with dementia, we started to invite caregivers to talk about their experience. And we basically make it look like a story. So things like, tell us how you noticed the symptoms with your mother or father, what has changed, what was the main challenges that you are facing, what have you done to cope with those challenges, and what could you teach other service or caregivers. So what could other people learn from your experience? It was interesting that people felt that what one is going through is possibly applicable to other people as well. So it wasn't a kind of a personalized experience, but also something that I could teach other people from. And finally, I know Diana is appearing there. Things like, and I got a good example of borrowing ideas from the UK in particular. We work with a group called Dementia Friends, who are under the umbrella of Alzheimer Disease International. And they have an ongoing program of educating the public about dementia. And they kind of have 5 messages that got repeated around. But the interesting part is that not just the knowledge, but what can you do about it? Or how do you want to change behavior? So what would you do to participate to make a change? For example, those who agree to subscribe to become Dementia Friends, they would choose to do a particular behavior. So either help a neighbor, or probably write an article in the newspaper, or a blog, or a tweet about mental health, or just go and sit with somebody, a neighbor or a family friend who's looking after a person with dementia, and relieve them and give them that mental support. So whatever, I don't want to sound like every little thing help, but something like in that context. So whatever kind of behavior can make a change to other person. Diane, am I allowed to say some more?
I'll give you 1 more minute.
Right. So basically, I would like to possibly close by saying the future. There are, obviously, our journey has kind of started the past few years, but we need to possibly go on and be up to date. So we upgrade our system and possibly go and use evidence-based interventions. So again, what can work and what would work in a long term, rather than focusing on giving leaflets for people that they might not be, most people have no time nowadays to read a leaflet. So how can we make this information accessible? How do we make sure that our information sticks in? And how do we kind of deal with people who have different ideas? And how do we possibly, because one of the examples I mentioned, the role of religion, most people, in Oman, for example, they take religion as very important. And there are a few times when a religious person will say things like, a person who's religious should not be feeling anxious or depressed. And in one occasion, one of our students tweeted this, and I went myself and gave them one feedback saying, you are part of the team now. I don't think it's helpful to spread such information. And also, if we have somebody who is coming to our clinic who has like a religious figure, we will ask them to probably tweet about the issue. So again, using social media, the power of social media, the issue about possibly making health education more accessible to people by probably inventing an app that has information accessible to people and make it more relevant to them. So in this case, how can I make life easy for my patients and our caregivers? And how can we help them to do their job in a more sustainable and for a longer time?
Thank you so much, Dr. Hamed. Eileen, I'd like to pass it over to you now to continue.
Hi everyone, my name is Eileen. I work as a psychological wellbeing practitioner as part of the IAP service. So that just means that I deliver low intensity cognitive behavioral therapies to all peoples from all walks of life. And the aim of it is just to kind of build optimal mental health well-being. So not only do I work with people that are from general population, but I have also worked with people inpatient as well, and with more severe difficulties such as eating disorders and psychosis. So that's just kind of like the context in which I do work. So I do work for people from all walks of life, different religions and different cultures as well. So I'm working.
Eileen, sorry, could you just speak up a little bit? Just a few people are asking.
Okay, I do apologize. My mic is not the best right now. So just to say, working to provide therapy for mental health difficulties, it's not unusual to come across people having very archaic ideas of mental health in general and what the service is able to do for them. And these are all under the stigmas associated with having a mental health difficulty and seeking help for these. One common theme I do find with people that I've worked with is that they have this notion that they're admitting to having a mental health difficulty is like an admission of some weakness of some sort. And this is across the board for both men and women, but it seems slightly skewed more in favor of men, and particularly Black women that I have worked with. We live in a culture that paints women as emotional and men as having to be strong, and this stereotype can be quite damaging in the perception of mental ill health. Statistics show that 25% of the population will have a mental health disorder at some point in their life. But by making this an issue of weakness versus strength, it creates a social barrier for people to, first of all, admit that they are struggling with their mental health, and then to actually seek the help that they need to manage better. And the implications of this is that, and it all accumulates to the point where some men will not seek help until it's getting to the point where it's too late, and then it leads to drastic measures. As I'm sure a lot of you are aware, men have a higher statistics of suicide than they do women. And this is often, this can also be associated with their lack of help seeking from an early stage. In some schools of thought, it's just seen as this is what's contributing to higher rates of suicide in men compared to women. Also, when this stereotype of weakness is applied to women as well, particularly Black women, there is this, this narrative of a strong Black woman, in quotes. This narrative held by a lot of my patients is as well generated by general society, places an extra burden on Black women to maintain a certain strength, even when their white counterparts might be struggling with the same issue. And like we see with men, this delays help-seeking behaviors and often leads them to be very unwell before they are able to seek help. Then they're seen at even more severe stages of their mental health, and the support that is then needed for that kind of mental health difficulty or that severity might be things like being admitted to hospital, which then creates a very poor image of the mental health experience. Also, I think it's very often for people to sensationalize the idea of mental health by taking the very rare and very extreme circumstances and applying it to all ranges of mental health difficulties, which again just fuels this stigma around mental health and mental health seeking support. Another theme I found across different groups of people is a misconception to getting mental health support is that needing a mental health support will kind of lead to some adverse outcome. For some people, this might mean socially, maybe thinking that people will see them differently, or they will be ostracized by their social groups, or how it would affect their jobs. For others, this was more of a medical medical idea that, you know, if they admit that they do need help, they will instantly be put on medication or forced to go into therapy that they did not like or even want to go into, or maybe even be forcibly admitted to hospital. Again, these are taking very rare situations and very rare and extreme situations and applying it across the board, when really the mental health services that we are known for work with patients, not against them. We don't do anything against the patient's will unless it is just to in those very rare and extreme circumstances. Another notion I've noticed with the patients I do work with is that one privilege that they will lose are maybe certain welfare privileges, such as being seen as an unfit parent and maybe having their children taken away. Now, not to say that this does not happen, but again, it is a very rare and extreme circumstances. But if you take that and apply it across all the board, it seems like a very extreme it seems like it's something that you would not want to go into by admitting to any mental health difficulties, even if it's something quite minor. And these misconceptions of what people with mental health difficulties experience are often blown out of proportion and are very rare, very extreme circumstances, like I've mentioned. In my line of work, for the best engagement in therapy, we often find that once we have hit some of these misconceptions, that they are explored and clients are given reassurances for these. For instance, with the misconception that, you know, admitting to some mental health difficulty is a sign of weakness. As a practitioner, I would often explore where these beliefs come from and have them reflect on what they would think if maybe someone close to them admitted to having these difficulties as well. Clients often find that they are more likely to be compassionate to other people struggling with mental health difficulties than themselves. And this is something that is also quite familiar with depression in itself. When they realize that they're not being as critical to somebody else, it kind of skews their view, like, why would I be then this critical on myself? Is this me, or is this the mental health struggle I am dealing with? And often that kind of changes their perception and reduces some of the stigma around it for themselves. To add to this, clients often find comfort and change to that perspective by using personal stories of other people's mental health difficulties, which is often included in treatment. In the IAP service I work with, we often use some booklets that might be able to help people kind of validate their experiences. And these kind of booklets often include a personal story of someone who has struggled particularly with what they might be facing, whether it be depression, anxiety, panic, sleep difficulties, stress. All of that is given in a personal story, and when patients are able to relate to that, they're able to reduce the stigma around it and think that it is more commonplace than they are originally aware of. Also, with the misconceptions of some adverse outcome, when it is identified, when it's identified what the misconception is, say of giving unwanted medication or of children being taken away, we often find this is fueled from a lack of information. And once information is given and reassurances are given, people feel more calm about admitting to their struggles and even giving more detail about that and actively engaging in support for that. So when mothers, for instance, come into our service, it's usually, or even fathers as well, we often have to take the names, the date of birth, and the schools that the children are going to. And often they think that it's just to kind of check in on them, when really we're trying to see what kind of support they might be eligible for, whether there are charities in the service that would work with them and give them that extra support to avoid the taking away of children. And I think that in itself, once that information is given, people tend to calm down. And often, once you find that maybe 1 or 2 times for seeking help for mental health difficulties, then it's easier to then admit to it even more often as you go down the line in their journey or in their lives. So on top of the things that we've already discussed, when working with patients, one way that I try to avoid people with their mental health, one way I try to get people with their mental health to fight their stigmas is by actively recognizing their strengths and highlighting that. So often I find that when people are struggling with, that are being very critical of themselves, often with depression or anxiety, sometimes it kind of skews how they think about things. Depression is very known for this. It skews looking at only your difficulties and not your strengths. And highlighting on those strengths is actually key in actually understanding that I can be strong while also having a difficulty, trying to combat the black and white thinking and bring in those gray areas, mixing that up a little. That often reduces the stigma around that. And another method is also by getting patients to let go of how they knew themselves to be. This narrative that they've painted of being the strong person, being the strong black woman, all of the, or having to not be so emotional as a man, all of that, it's we have to kind of take that all away and then bring in what we understand is a new normal, a new way of painting themselves, bringing both soft and bringing both weaknesses and strengths, so soft and hard bits together in this new normal that they can narrate for themselves. This new narration can actually help them building this new persona instead of relying on the old one that was unable to seek help, but this new one that can be strong and still seek help as well. Personally, in my line of work, I also find that women are more willing to discuss their difficulties than men. And as a single white British women in particular are more likely to do that. And I think this comes from being part of a majority, which gives an anonymity to admitting to mental health difficulties. Whereas on the other hand, that black women are often seen as, as almost being a representative for their race. And they often find that, if they start to admit to mental health difficulties, it's not just that one person admitting to it, but a black woman is admitting to that. And therefore black women are seen in this light. Often this comes from the situation that the current social society that we have it now. And I guess it takes a lot of work to really break those narratives apart. Lastly, I'm just going to say that as much as we do a lot of work to kind of help with reducing the stigmas in my workplace, I think social media, although has a long way to go in its culture, has actually done a lot in being able to break down these stereotypes by bringing a lot more information that people might not have already been aware of. I think that's such a key point, as well as these personal stories in terms of reducing the stigma around mental health. Okay, I think that's all I have time for. So
sorry, Eileen. Thank you so much, though. Her Highness Sayyida Basma, I would like to pass it over to you. You are over.
Hey, good afternoon to all of you. I wanted to thank the Anglo-Omani Society for this opportunity. I'm really happy to be here between lovely people talking about what we love most. And I'm glad to have my old colleague with me here also, Dr. Hamed. It's really exciting when you hear all of this. And I really believe that everything we hear today is part of a story. And I think that's the thing that I really used a lot from the beginning of when I started working in this field. When I started working in this field, I worked in SQUH, in the University Hospital. And at the time, everyone told me that nobody is going to come and see you. It's stigmatized. People don't like talking about it. And the shock was that actually there was a lot of people that came. And it's because Oman has, so you have the capital, Muscat, then you have the south and the north. So people from all of those places would come because they felt that I wasn't maybe in Salalah, so nobody would know. I'm in Muscat, so people from Salalah would come and from other places. And they would talk of the most intimate stuff that they would be going through. So that showed me that no, people want to talk about their issues. They want to seek help, but they're just worried. So how can I change that? Now, being in my field, a clinical counselor is totally different than being a psychiatrist, than being a neurologist, and working in SQH. A lot of people didn't understand, what is she doing? Is she a social worker? What is her place? And a lot of times I would work with psychiatrists and their timing of seeing a client was way shorter than the timing that we would see a client. So we would sit for 45 minutes and they would be a bit less because that's how it works. So in this 45 minutes, I would do a lot of things. And I noticed that creativity would always win with my clients. Creativity and simplifying, making things a bit more simple when we talk about it. I noticed that a lot of times when we talk about mental health or psych, we make it a bit complicated because we talk to people like the way we learned from university, and they don't understand that. These big words and these big equations for them, it's just more complicated than what they're living right now. So it was a journey. It was like a story. I had to check how people would feel, what would work the most. I would go to different wards in the hospital. I wouldn't just be in one ward. I'll go to pediatrics. I'll go and work with the cancer patient, the adults, the people that are drug addicts. So it was all like a big way of research just to understand how can I help people in a way which is acceptable, which is also meaningful, and which would automatically help any kind of age and any kind of educational background, because that was very important. After that, learning all of that, another thing that helped me to understand what I need to do is traveling. So I trained a bit in the UK, I went and trained a bit in the US, I had studied in Jordan, I went to Egypt, I studied in Australia. I took all the information from all these countries and thought, so what's the difference between us and everyone else? And honestly, I feel there is no difference. We're all humans. We all in the end have the same issues. The difference, maybe the one difference that I must say, is the awareness and the campaigns of awareness that is done all around. And that is something that has to be done much more in Oman and in the Arab region in a simpler kind of way. Like Dr. Hamed talked about lovely points of how he gets people to talk about their story. And that is very important. Because when you hear a story from someone else, then you feel, wait a minute, that's something I'm going through too. Today in this group, I'm sure a lot of things that we're gonna say, we're gonna feel like, wait a minute, I feel I'm going through that too. So it's like a big group therapy. And I always felt that group therapy works way better than individual therapy. So getting people to talk about their feelings, we had a campaign, we still have the campaign, it started in 2014, and it's called Not Alone. And the idea was people talk about their stories and we listen, people use art, use music, use all these alternative things which people, especially maybe in Oman, think, what's that got to do with medical? What's art got to do with medical? What's music got to do with medical? What's meditation got to do with medical? But actually it worked a lot, and especially with the younger generation, which now they are going through so much, maybe even more than the older generation, because of what's going on around them. And through art and through poetry and through all these creative things, people were more willing to talk about how they feel. Now, the problem that I would say that faced me mostly is getting people from the society who are educated, who have good places in society and doing a lot of things to actually believe in helping in a campaign for mental health. which sounds, you know, sounds unreal. Like you'd think the moment you talk to somebody about a campaign about mental health, they'll jump for it. But no, that wasn't happening. And that was my stress. And that was something that I had to make people understand how important it is. As we know, mental health grows and is in everything. And it's important to everyone in the society. To be able to grow, you need to have a good, balanced mental health. So I started talking to people about how anyone could go through stress and depression and OCD and anxiety and all of that. And I tried to show people the difference between what we go through and what people who are really not well and how they're feeling. Because everybody would say, there's nothing wrong with us, you know, we're okay. But then that's not a normal thing, because obviously we all go through all kinds of stresses. So I started to talk about that. I started to talk about how alternative ways in therapy is very important. I started visiting places in Oman, for example. I would go myself to schools. I would talk about bullying, because we found that that was becoming a lot, and a lot of youth were using that to hurt each other in media, suicidal threats, or talking about it all the time. And every time I would hear the same sentences, this only happens in this region because we don't talk about it, it doesn't happen abroad. And I would say, no, it happens abroad as well, because in the end, we're all humans. But it's the way that we present mental health, it's different. The other thing that I would always hear, which Dr. Hamed talked about as well, is the evil eye. And then I thought to myself, okay, how can we tackle this problem? Because this is to do with culture, it's to do with the environment you're growing up in, and there's a lot of things that's linked to it. Then I found out it's easier to say that I'm hit by the evil eye than to say that I'll work on something. Because if I'm hit by the evil eye, it's nothing to do with me, I'm not going to do anything about it, I'll just go to someone and they'll help me out. But when they come to do therapy, you have to work on it, and it's way more stressful for them. So that was an easy way. So I started talking to them about how I grew up. I started to talk about how sometimes I would feel that way, and slowly you'd find people feeling more comfortable when you start saying, you know what, things like this sometimes happen to me too. I get scared, I get worried, and I get stressed too. And then they go, really? And us too. And it does a dialogue, it does a conversation, and that's the importance of story and creativity in it. So doing all of that, and then trying now to come on and always continue with the campaign. Because again, you don't want to just do it twice a year. So now what can we do? So starting to do competitions, but the competitions would have women with mental health and art. How can we, you know, combine both things? And a lot of people will tell me, why are you always focused with women? And I'll tell them, I think it's also because you see me as a woman, you think that's what I'm doing. But actually, I think when women are okay and they're doing well, then therefore their kids will do well, then for the society will do well. So it's a long chain that, you know, comes together. And at the same time, we do care about the mental health of the men, because I actually feel sorry for them, because in every background and in every environment, boys are always taught that you're a boy, you have to be strong, you can't cry, you don't express, boys don't cry, and all of that. So they grow up like that, keeping all their emotions inside, and then if they were to get angry, they like erupt. So it's the way, again, us women and the fathers are supposed to bring up these kids. So I always say it's not that men don't come to seek therapy, is they feel shy because they're taught that they are men and they have to be strong. So that was something else too. So we got men talking about mental health, their story, about the things that they are scared. And people were shocked when we talked about men getting hit, for example, in a relationship. A lot of people were shocked. They were like, what? That happens to men? So again, that happens in every society. That happens in Oman and outside of Oman. Also, when I was traveling, I would actually ask people, would you have a problem with people coming to visit you and seek help? And when I went to the UK, a lot of them said yes, a lot of them don't come. When I went to Egypt, they said the same. So we actually did a board and said, okay, how can we help them? What can we do? And we discussed, again, alternative ways, talking, normalizing a bit of stuff, making a campaign that's more easier for everyone to understand. One of the things that I really like about Not Alone, our campaign, is not only psychologists that are in it, it's people from society. I am a strong believer that society can help society. And we don't have to keep on waiting for the government. If you feel you want to make change, change begins with you and you only. So getting everyone from different fields to come and help, and then showing society, look, everyone can have something to give to the society and to talk about mental health. I mean, he's a manager, she's an architect, he's a policeman, I'm a therapist, and we're all talking about it, so it's okay. Now, but the funny part I want to just talk about really fast, because I can go on and on and on and on, is actually I've seen a shift, a very big shift. It's an annoying shift, but it also has a positive and a negative to it. A lot of people who have nothing to do with mental health whatsoever talk about mental health. And this is a very big problem. If you have people in media who don't know anything about it and just preach about, oh, you know, you have to do this, that, and the other, but they're actually themselves are not doing well, and the young generation seem to want to listen to them more than us. So this was another thing that we had to learn. How can we be more interesting? How can it be not dry? Because they listen to I'm not demanding bloggers and influencers, but they listen to them, sometimes even more than people who are in this field. So what is the problem? What was the mistake? Again, it's the way we present ourselves. So I actually see a shift. Yes, I'm finishing. I see a shift now of everyone and anyone talking about mental health. That is a danger, because we're dealing with the mind. And once the mind is not functioning well, as we all know, everything doesn't function well. So I think we have to unite to kind of be creative, be different, simplify it a bit, because sometimes it's a bit too nitty-gritty. When we do our talks, we can do all that nitty-gritty and hard talk and all of that. Thank you so much.
Thank you so much, Sayyida Basma. And finally, I'd like to pass it over to Dr. Richard.
Thank you very much. And really, I think most everything has been said already. So the speakers have done a fantastic job. If I just say a little bit about how I hold this in a global company. It's a big company, 70,000 people, and it's going through massive change at the moment, turning itself into an integrated energy company, changing almost everything internally, and also in the midst of the pandemic, the biggest health issue that we all, almost the biggest health issue we all share across the planet at the moment. So let's just talk a little bit about stigma. We've been talking about mental health in BP for a long time, but when we decided to refresh our strategy, we thought quite long about, should we call it psychological well-being? Should we use mental health? And we decided, let's use mental health. Let's talk about mental health, because otherwise we're going around the issue and we're trying to make, and we actually thought quite hard about this, particularly in countries where the word mental, as Dr. Hamed said, may be associated with mad, bad, sad, or somebody who's possessed. And we felt really we have to hit this head on. We really have to tackle this head on. So that was the first thing we agreed to do. We'll do this. And then I think the second thing was to make it, as Her Excellency says, this is everybody's issue. So we talk about, Eileen, I think you said 1 in 4 people will suffer from a mental health problem. Well, maybe so, but actually that means 1 in 1 of us are affected by mental health, 100%, 100%. If it's not me, it's not my neighbor, it's not my family, it's not my friend, that is 4 people. So that means every one of us is touched by this. And I think that's a really important point that we make. In a sort of company setting, the other thing we can do is, again, to normalize this. We all have mental health. We all have physical health, and we talk about it really easily. So we talk about, you know, I had a muscle strain, I'm walking with a limp, or I have a broken arm or something, and you get sympathy, and somebody says, how are you doing? But if they think you may have a mental problem, we don't know how to talk about it. We don't know how to have that conversation. But actually, it is the same. You know, I have mental health. Sometimes I have a great day. I feel really good. I feel invigorated and energized. Sometimes I don't feel so great. Maybe I was worried about something. I don't sleep so well. I wake up in the morning and I'm feeling a bit stressed. Now that's normal. Sometimes it might be eating me a little bit more, and I should discuss it with somebody else. This is maybe my friend, maybe my partner, maybe somebody I trust, or maybe I have to talk to somebody who is private from this, because I wanted to really reflect it with somebody who really understands. And that's like going to a counsellor or to an IAPT or to an EAP. And it's really just like having physiotherapy for the mind instead of the body. You know, we wouldn't be surprised if somebody has a muscle strain, they go and have 4 or 5 discussions with a physical therapist, and they come back perfectly good. And it's the same with mental health. For many people, we just need to have some space and some conversations, and then we can do this. So I think tackling that, in really trying to normalize it, has been really very, very important for us. I think then part of that also is to make it relevant in a business setting. So I've worked really hard on the business case for this. And what I can tell you is when we really genuinely care about each other, business gets better, where you actually have people who are more energized, they come to work better, they are more connected, they trust each other, and actually their well-being and their mental health is in a much, much better place. So we know about this, but actually, to your point, Eileen, we're worried about, well, you know, maybe I might lose my job if I have some problem with this. Maybe if I call the EAP, somebody will know about this. So there is a lot of fear and concern and worry about that sort of thing. So in 2018, we worked with one of our most senior leaders, who's now our chief executive, and we were with Mind, the Time for Change campaign, and we did a video, and we had talking heads. We had 5 big leaders talking about their own mental health and the mental health that they had in their families, and a big guy who was a driller. He did drilling. He was like a rugby player who talked about what help he got from EAP. And it was amazing. It was amazing. First of all, we had something like 4,000 people listen to this broadcast. We then had 300 people on our internal Yammer chat talking about their own mental health, thanking us for the conversation, and then the stories and the narrative. Other people are like me. This starts to roll some more. So, and also the other interesting thing, which I shared with our chief executive at the time, was people spent more time looking at this video than they did on the annual results of the company. It must be interesting. It must be relevant. It must be important to them. So we were able to get some momentum around this is a really important issue. We must talk about it some more. We've run that campaign over 3 years. And in the second year, we went from, oh, the boss is a bit like me. I can talk about this because this person's like me. When you have a heroic boss who looks like they're up here, like on a pedestal, it's very difficult to share how you're feeling. But every time a senior leader talks about their own vulnerabilities, their own mental health issues, and their own stress, which we all have, I do, everybody does, it makes us a little bit more like the person who's next to us. It makes it easier to have this conversation. So this is a really, really important thing that we do. We have, and I think that's also where these influencers come in. They make it more normal to have mental health and talk about it. So I think that's been a really important thing. Now, I wouldn't want to just say that's it, because actually what we have also looked at is in an organization, you have to have a prevent, understand and support approach to this. So when you look at a big engineering company, now I know this is being recorded, so I have to be a little bit careful about how I say this, but you have a lot of people who are financially driven, or they're legal, or they're engineers, and you know, they'd like to talk about numbers, they'd like to talk about projects, they like to talk about big project stuff in difficult places, because that's what they do. They don't talk so easily about their feelings. They don't find it so easy to talk about feelings. So we have to really understand that, and also realize that in some cases when they have a bad conversation with somebody, it's not because they're being unpleasant deliberately. It's really they just don't have the conversation skills. They don't have the mental health literacy really to have that conversation with another person in an effective way. So what we have done is we've used surveys to get at what people's well-being is like, and I've used some research which we've published. You can look it up on ResearchGate or anything if you like. And what you find is that when leaders genuinely care about their employee and the employees recognize this, all these other things improve. Safety improves, ethics improves, attendance and staying with a company improves, and people's general work output also improves. And you can actually demonstrate this. You can really, really demonstrate it. So you make the business case for it, and then we start to change the way we train people. So we give people skills on how to talk about mental health in a more easily way. So we've built this into our Leadership Academy. We've made it part of if you're going to be a leader, you need to talk about this stuff, because actually everybody has this. And if you want to be a good leader, you have to be able to talk about it. So I think that's a really important part that we've put into it. And I think also some statistics are helpful. I think the big general statistics can be a little helpful, but it's more helpful if it's your own data, if it feels like it's your own data. So we've looked at things like EAP, and I took over responsibility for that, and we rolled it out everywhere, because EAP sometimes has good reputation, bad reputation. But what we found was there are some places where people don't use it. Okay, why is this? 3 things, I think. First of all, I don't even know about it. Secondly, I don't trust it. Maybe the data will go somewhere and I will lose my job. Thirdly, I don't think it has any relevance to me. So these things can be tackled by local discussion and culturally sensitive discussion. And actually the EAP has to be in the local language, it has to be locally culturally sensitive. And my organization, I have a small group of doctors and health professionals working with me, but 60% of them have English not as their first language, and most of them are working and living exactly where they are based. And what I believe is, whilst we can train people in the UK, in Australia, in all these lovely places, America, in technical skills, you cannot train people to understand the culture of health better than living it from birth. Because actually, this is something you can read the book, you can read about the culture, you can understand these little things, but you will always make a mistake. So I have Dr. Isa Al-Sinawi, who's based in Muscat. He is from Oman. He does all the cultural translation for me, and he does a fabulous job. And I have Dr. Anatoly Sharakin, who's based in Moscow, and you can tell he's Russian. And then I have similarly someone who is from Vietnam, and so on. In a team, and Spanish-speaking, Portuguese, they can do the translation of the cultural piece, because it may be that it isn't normal to go to EAP. You go to your religious leader, you go to your grandmother, you go to a family member. And we must acknowledge that this is the way these things are managed in different places, sometimes in good ways, sometimes not so good. But we do need to understand the cultural model that is there. So I think we do the training. We also do, we look for hotspots where the well-being is going in the wrong direction. And we look at things to do with, as I say, perception of care. Do people care? We also look at, are people feeling trusted? Am I trusted to do this job? Do I get support when things go wrong? Is this a place where it's safe, psychologically safe, to speak up about these things? And also, do I have some problems with things like workload, too much work, the wrong kind of work issues that need to be dealt with? And we can find hotspots around the places where people work, and we can make some interventions, and we can go in and do some more detailed listening sessions, focus groups with local translation. So Vicky Wei Lin is my Chinese partner, and she is in Shanghai. We did the whole of this assessment in Canton in Chinese. I couldn't understand any of it, of course, but what I did is I did a presentation about it, and I had slides in the right language, but then the discussion was in the local language. We can't discuss intimate things, and we can't argue well in somebody else's language. So why should we try this? So I think that's, in organizations, this makes a really big difference. And also the language piece, I think it's important to come back to that. We talked about suicide. Of course, if you come to the West and you come to a place like UK, for many years, it was a crime. People were committed suicide. This word, it means you just did a crime. You committed a crime. This is entirely wrong to use this language, but it's become the way people have talked about these things for many, many years. So we have to address this and talk about people who have tried to take their own life. And in an organization that may not realize how important this is the biggest killer of men under 50 and of women under 32, you know, in the country. So we must talk about it, because these people are working for you. I think also, coming back to the business case again, in a company that's going through rapid change and needs to have talented people, we have to think about neurodiversity. The skill sets that people bring are very, very many and very varied. If you try and just get lots of general people who do the generally enough, you will be able to have a generally good, okay company. But actually, if you want to be the best, You need to get the best skills across the piece. And we know some of the most clever people, some of the geniuses even in history, had severe mental health disruption, but they made massive difference to computing, to music, to art, to all of these things. And unfortunately, many of them did not have the support that they needed to have a healthy and happy life too. But actually what we can do is we can really acknowledge that in our own work situation, and really use that with our managers to make sure that they realize why this is important. I think I see my time's probably coming up too, so I'll stop there, and happy to take some questions.
Thank you so much, Dr. Richard. And thank you everyone for all of the questions. So I'm going to get straight into them because Eileen, I know you have to go in a couple of minutes. So I'm going to jump into a question that was asked for you. And it is, Eileen, you spoke a bit about the different demographics in the UK and how much they speak about mental health. Do you notice any differences with non-British white people, those who move to the UK at an older age, especially from different cultures? Do they find it more difficult to find counsellors who understand their cultural background, or does this not matter?
So I've worked with a few people from New Zealand and Australia, and I find that they've got a different type of mental health support. So I think it's more the idea of what they will be receiving when they come into our service is something that they need a little bit more information about. But once that is given, it kind of eases their expectations on what we can provide for them. It doesn't, however, kind of limit their ability to talk about their mental health struggles. And actually, I find that people who have come from places like Australia and New Zealand are able to talk about it a little bit more clearly, because they in their countries they have their service is almost it's a mixed bucket compared to the UK, where if you go to one service, it's focusing on one thing. Like the IAP service, it focuses on CBT, whereas and there is some opportunity for counselling. However, if you wanted something a little bit more in depth, you'd have to go somewhere else. So when they come in, it's about giving them that information, but I have not seen it kind of really stop them from talking about what they do need, and they're happy to kind of be directed to where they can get the help that they feel will be most beneficial for them. In terms of people coming from America, I think I haven't come across a lot of people from America or Canada personally. But I do find that maybe the mental health discussions would be different there, just because in America, for instance, you would need health insurance, whereas here you can get it free on the NHS. And I don't know if that has been translated across very well. But again, the first step, if they are experiencing mental health difficulties sometimes, is to first of all go to their GP, and their GP knows exactly what to do to get them the support that they need. So I haven't seen any discrepancies there so far. Was there any other part of that question that I needed to answer that I haven't?
No, I think you, I think you completely nailed that one, so that's fine. I know there's one more for you. It was, someone answered while you were speaking. So if stigma comes from limited knowledge regarding mental illnesses, what can we do to increase awareness, just knowledge? I think this is for all of you, but I don't know if you have anything before you go.
Sure. Like I mentioned at the very end of my discussion, I think social media does a very fantastic job about promoting mental optimal health. There is a lot more information out there, and I've seen a shift, particularly in this era of COVID, that everybody being online, this is something that's been really out there. Now, I can't tell if I'm kind of skewed in my accessing of these kind of sites, or accessing this information because I'm more attuned to it, this being my line of work. But I've also noticed people across the board, people that I associate with that might not be as in tune to mental health, are seeing these things come across and are getting some kind of reassurance from it, some validation from these things that are so obvious now. A lot of psychologists, a lot of people with mental health backgrounds are also putting up mental health pages on Instagram, Facebook, Twitter, and are giving as much information as they can. And it's actually been, there's a lot that has been promoted as well, with kind of giving that information out there. Social media being the #1 way to help that, but also knowing that the social media is a culture in itself that does need to be tapped into. It can make or break you in a sense. You can see the cancel culture of social media at the moment that can be very detrimental to people's health, but you can also see them being very supportive and promoting of mental health.
Thank you so much, Eileen.
I do apologize that I do have to leave now, but thank you so much, and it was lovely to speak with all of you lovely people.
That's completely fine. Take care. Thank you.
Bye.
Next question, Dr. Richard, this is for you. How much of responsibility do you believe employers have over their employees' mental health?
Yes. Well, actually, I think they do have a considerable responsibility, and in some cases it's in law, particularly in Canada and a number of countries, the requirement, and UK, to do some sort of risk assessment of how you may affect people's mental health is part of the regulatory framework. But I think, as I said, a number of mental health disorders or conditions or issues may be nothing to do with work directly, but they will impact on people's ability to do their work or to attend work or to actually be how they're recognized in work. So there's a direct relationship there. But I think, again, just looking at some of the research on this, if you look at what helps people to feel better at work, it's the demands on them, it's the support they get, and it's the degree of autonomy that they have over their work. And I think if you look at those three things, those are three things that are very much in the gift or the responsibility of an employer. How much work do I do? Is it impossible for the capabilities that I have? Is it the right kind of work? So I don't have the skills to do this job. So that might be an issue as well, around the sort of quality of work and the quantity of work that people have. And then being trusted, how do we feel if someone says, get this done, do it as I say, and do it by yesterday, command and control. This does not actually improve people's mental health at all, and actually it generally doesn't improve the productivity of an outcome either. When we care, when we involve somebody and we ask for their help to deal with that, we get a better outcome. And you see that no more clearly than in healthcare settings themselves. When we care about the doctors and the nurses and the healthcare people, including the porters and the cooks and everybody else, actually patient safety improves. It's proven. Richard West has done some fantastic work on this that shows a really clear relationship between how we care at work and how you deliver the outcomes your company or your organization wants to give. So it's an everybody wins if we do that. I think really it's really important to do that. Yeah.
Oh, thank you. Is there a shift in perception of mental health in younger generations, for example, millennials and Gen Z, who are a lot more active when it comes to storytelling / consuming their kind of info through social media? Whoever would like to answer that.
Could I just add a little bit on that one? Because actually, I'm interested in science in general, and one of the things I watched in 1967 was the moon launch, going to the moon for the first time. I visited the Space Control Center with one of my colleagues even in January, and which was a fantastic visit. But what I was captivated by, the people who actually managed to get everybody back safely, their average age, 26 years old, 26 years old. And 10 years earlier, when they made the promise to do this, they were in short trousers and in kids in school. Now, these are people who will change the world. These are the people who change the world, and companies and governments and we want these people. We want them to be engaged in what we want to do. So actually, this is really important that we reach out to this generation. And also they are driven massively by values. They want to save the planet. We know that. They want to save everything. So you can't just have a story and then when they come and join you, oh, it's not really like this in here, because they will leave. They will go. So again, whatever work type of life we're in, whatever occupation we're in, if we really want the people who are going to save the next generation, these are the next generation, and we have to reach out to them.
I think I'll also, exactly what you said, Dr. Richard, I love that. We look very closely into the young minds. We call them young minds. Sorry about that. Not that young, am I? Okay, so we have Young Minds. Young Minds was for young people, and it was actually, they were talking about their stories. So even the press conference, they were talking about, they were there. It wasn't only adults, because we noticed everything to do with young people, they're not there. If it's to do with children or youth, it's only adults talking about them. Like today, we're talking about them. So we put them in the press conference. They led the press conference. And then what we did was from age 10 to age 22, we did 3 groups in one day. We had from 10, I think, to 14, 14 to maybe, I think, 16 and older. They were talking about issues in mental health in these 3 groups. And we had one group, which were the parents talking to each other about their issue with bringing up this young generation. Now, these young groups, besides that, they did a panel, but they were asking the minister, they were asking the doctor, they were asking someone from the royal family how they grew up. Did they get bullied? Did they get through any stresses? Because kids sometimes think that that didn't happen to us. That only happens to them. So it was good hearing the questions that they were asking, you know, these people, these adults. The same thing with Young Mind now in COVID-19. Every Saturday, they meet up and they talk about issues. So young people, again, talking about issues together. In Not Alone, they come with us. We have a convoy and they talk about, there's a whole section just for them. So yes, I agree. They are the future and they need our support, because sometimes I feel they get very, very sensitive and very, very defensive. And it's because sometimes they're lost. What do we do? And we make it cool. We make mental health cool. Yes, they come and talk about poetry at the clinic. They talk about their stories. They call it poetry. It sounds like rap to me, but whatever rocks their boat, I'm happy. So yes, it is a nice vibe and it gives you a good energy as well.
Thank you. Going on to the next one. Do you think the Middle East is more open to different kinds of therapy, such as hypnotism, than the UK? Are people more cautious and distrustful of different therapies in different countries? Any comments for anyone?
Dr. Hamed, do you want to say it? I find it normal. They come and they do it. They love everything new. They actually don't like the traditional anymore. They want new because it doesn't sound that it's got to do with mental health. It's a new lifestyle. So that's my take. We have Serenity and we have Serene, and people would rather do meditation, hypnosis, all of that than come. So let's see, Dr. Hamed.
That is right, because I'm seeing that as well. People are more keen to doing meditation and listening to relaxation music, and sometimes they would probably invest into that and take courses or sign up with a therapist. And well, we have to be very careful about what to advise, because some particular people who have like a major depressive episode, it's time to step in and say, well, probably you've tried this already, so it's time to go for a kind of a more evidence-based, like a CBT or family therapy or other kind of. So the idea is that to suggest and guide, but not so much interfere. But I would agree with the idea of people are more open to explore new ideas. Yeah.
Okay, I'm just scrolling down to quite a big question here. In sport, there is currently some work being done at Oxford looking at the importance of mental health on actual sporting success. The idea being, if you link mental health to tangible output/gain, you're more likely to get big organizations to engage and spend money on supporting athletes. Sadly, sometimes the health imperative is not enough and companies need a monetary incentive. But there is so much data out there that shows the correlation and causality between improved mental health and improved performance. Is this being widely broadcast and shared in the corporate world? I think that's for Dr. Richard.
The answer I would say is yes. I work very closely with a psychologist who also advises rugby teams, national teams, and local teams. He is also a professor of psychology. And works very closely with me, and we've written a number of pieces of research together. I think there's a danger and a plus with some of this. Certainly with sports people, what he finds is there is a very fine line between, if you think about rugby or contact sports, between being too aggressive and then you're sent off the field and the team will lose. So trying to manage anger is a really important piece of that psychology in sport. Equally, there are people who really have trouble getting out of bed in the morning to do stuff. So they need motivation to actually be as good as they can be. So I think some of these lessons are very, very transferable into any situation, those things. But I do think the danger is that in the corporate world, if you start bringing in people talking about Olympic athletes, there's a sense, do we have to be like an athlete? Do we have to be like an Olympian? You know, and it's a sort of, it's not like, it goes to that, this is not like me. This isn't normal. I'm never being an athlete. I'll never be as good as that. So I think, like all these things, you have to take the pluses and the minuses of it. But what we have done is we've used some of the training techniques for there, and we've shown things like people's capacity for rumination and worry can be reduced if you use some of the techniques that are good in athletic settings. Some of the training that we've done on that we've found lasts for at least a year when you reevaluate it. And again, we've tried to sort of look at that, do controlled trials and publish it, so that we are testing out evidence base for this. I think it was said earlier that there's a lot of people who think they know a lot about mental health. I'm not an expert, but I am very inquisitive, and I'm also very searching for evidence in anything I recommend. And I think that's really, really important. And sometimes one of the worries is in training people to talk about mental health, it's not like regular first aid. I don't want to get into a difficult area, but first aid is often a very short contact with somebody who might be dying from bleeding or something like that. And you never form a relationship with the patient, and then you go away and you give the person to the ambulance or to the person who can deal with the next piece. I think sometimes we think in mental health it could be the same, but actually you can easily drift from helping people by talking into developing a therapeutic relationship with the patient, which may not be the right thing. So I think we've just got to really be very thoughtful about all of these things we see in sport or in the public setting, and be very, very careful, but also innovative and creative about the way we deal with these things, for sure. Yeah.
Thank you. Well, I would love to continue with the questions, but I have overrun by quite a bit. So if anyone does have any questions they really would like answered by any of our panelists, please email them to me or to our RSVP inbox, and I promise to get them answered if all of you don't mind answering the questions as well. I'm just putting you out there. But thank you so much to our panelists. Thank you for doing this. You guys really could have carried on talking for such a long time, and I wouldn't have stopped you if I didn't have to. But thank you for everything. Thank you to all those that joined, and this is recorded, so will be available on YouTube to look back at for reference. Thank you so much.
Thank you. Thank you for this opportunity. Goodbye.
Bye.
You take care. Bye-bye.